Science, MAHSA University. And good afternoon, welcome to all to this joint webinar between Faculty of Health Sciences, MAHSA University, and Faculty of Public Health, Universitas Sriwijaya. The webinar today will be on the knowledge sharing, COVID-19 management in Malaysia and Indonesia. I am Nur Safarina. I am lecturer from the Faculty of Health Sciences, MAHSA University. I am the moderator for today. First of all, I would like to introduce our speaker for today. Okay. Firstly is Dr. Najma. Dr. Najma is from Faculty of Public Health, Epidemiology and Biostatistics, Universitas Sriwijaya. She has a teaching experience of more than 12 years and published numbers of books and journals in related to public health. Welcome, Dr. Najma. Next, second speaker is our own Mr. Sundararajan. Okay. He is from Faculty of Health Science, University. He was an environmental health practitioner working in Ministry of Health in Malaysia for more than 20 years and has teaching experience of more than 12 years in both public and private universities. Yeah. Welcome, Mr. Rajan, to our webinar.
Hello, good afternoon.
As we know, the fight against COVID-19, the fight against COVID-19, and there are actually some countries which is expecting for the second wave. Actually, there are some countries already embracing the second wave. As this is a novel threat, so every country have their own what we call as protocols and policy they come up to curb with this situation. And this all action taken is all different from one countries to one countries. And this end up will result in a different degree of success. Dr. A paper to Intersection Journal on August 2020, Australian National University. Please welcome Dr. Najma to present her research on health workers' vulnerability to COVID-19 in Indonesia. Okay, please, Dr. Najma.
Thank you very much, Salvina and Dr. Rajan and MAHSA University for this joint webinar with the Faculty of Public Health, Sriwijaya University. Today, we would like to share our current research, health workers' vulnerability to COVID in Indonesia, caste, loyalty, broken trust, and how Indonesia mitigate COVID-19 in Indonesia. Welcome to Indonesia. We have over 270 million population, 9 times over compared to Malaysian population. And our inhabitants scatter in over 5 big islands and over 10,000 small islands. Move on to COVID-19. This is the update, the data of COVID-19 in Indonesia. I want to show you the data of COVID-19 today on the 8th of October on this site and the last 2 weeks. Can you observe it for 1 minute? What are the difference from the number of the cases, the number of the deaths, and the number of the recovered? Within 2 weeks, currently, the new cases are reported about additional 60,000 new cases within 2 weeks and over 1,600 new deaths in Indonesia. Over 30 days, and let's move on in Indonesia. Indonesia is the second highest reported of COVID-19 cases, yet the chance of testing in Indonesia is much more lower compared to our neighboring countries such as Singapore, your country, Malaysia, and Philippines. And within 2 weeks that I said before that when you observe the data today and the last 2 weeks, there is additional 60,000 new cases within 2 weeks and additional 1,600 new deaths. Over 30 days, there were about 2,000 to 5,000 new cases daily in Indonesia. Compared to the early of pandemics, the increase of the new cases lower than 500 cases daily. Fortunately, the recovery percentage has reached about 70% right now. To understand Indonesia, please welcome to Indonesia and how Indonesia mitigate COVID-19 in Indonesia. It appears that Indonesians didn't attempt to mitigate COVID-19 in the structured way. From January to February, Indonesia failed to detect COVID-19, while the neighboring countries such as Malaysia, Singapore, Thailand reported their first cases in these both months. In March 2020, the first cases were announced, yet in this month, we deal with the shortage of personal protection equipment because in the last 2 months, a lot of export masks to other countries. From April 2020, the government start to introduce the social large-scale restriction, or we call it pembatasan sosial berskala besar atau PSBB. However, the implementation of PSBB in each city and province was based on the initiative and the needs in each local government. In Indonesia, we have 34 provinces and we have another local government around over 500. So it depends on the initiative, not because of the central government to say so and we follow that, but it depends on the each province. Interestingly, in the May, the government introduced the concept of new normal that followed by the local government and may be interpreted that back to normal. The propaganda associated with the term new normal pertain to adapting the new habits in the July and August. The government just aware that the new normal term is not correct, so they changed into the adapting new habits and focus on recovery, economic recovery. And now, just a few days ago, the president introduced another new approach to mitigate COVID-19. They call it mini lockdown. We just see what it will mean and how it will be applied in our beloved country. And now, I would like to share why we focus on the health workers. They are particularly vulnerable to contracting to COVID-19. Worldwide, over 10% of all reported cases are health workers. Currently in Indonesia, there were reported 130 doctors and 92 nurses passed away related to COVID-19, and over 1,000 got infected COVID-19. However, there's no officially report that available in the Ministry of Health regarding the mortality or morbidity rates of health workers exposed to COVID-19, making it challenging to find accurate data of how many health workers have been infected or died from COVID-19, or it's just iceberg phenomenon. We conducted a qualitative approach by analyzing statements from the government task force for COVID-19, the family of the doctors or the nurse that viral on the social media. We present 4 different cases purposefully to gain deep understanding of health workers' vulnerability to COVID-19. Later, you can read from my slides from Anna, a health worker who passed away during her pregnancy, or Adi, the young doctor who got infected COVID-19, and he may spread his COVID-19 to his father, his mother, and his brother who passed away within 2 weeks. And another 2 stories from the senior specialists that passed away, one during their hospitalization from another disease, not because of COVID-19, but because of stroke. But he may got COVID-19 during the hospitalization, and another may got COVID-19 during his private practice. what we can learn from this study case in Indonesia? I will not tell you one by one. Later you can eat the discussion and the tension because each story is so unique. And I use pseudonym in this analysis because it's so confidentiality in our country. So what I want to say to you as of opening of this webinar, that to conclude that there is complexity of COVID-19 transmission among health workers. Well, we cannot blame patient. The patient are the main causes why health workers pass away because maybe he didn't open their COVID-19 status to the health workers. That is the common assumption of health workers' vulnerability in Indonesia. Health workers' stories provide complex explanation and intersecting reasons why the high rates and vulnerability among health workers to COVID-19 in Indonesia context. There is the notion of shame, there is a silence surrounding health workers. So there is also the loyalty on the profession as health workers. So we cannot share a lot of things to the public. So there is a lot of complex intersecting, and the culture of in Indonesia that health workers have the highest position than patient, and there is asymmetry information between health services and patient. It happens still in most developing countries. So additionally, unfortunately, most information regarding who was infected is confidential and not available in order to limit the stigma against health workers. Patients may not know their own COVID-19 status, lack of access to COVID-19 tests. Therefore, they may transmit the virus to health workers or other patients. Remember, the chance to access COVID-19 tests is different in each province. You cannot say that in Java there are a lot of tests, but in Sumatra it's not like Java. So it's so disparity between province in Java and province outside Java. We argue that the failure to understand the complexity of the COVID-19 infection may endanger health workers, their patients, and their families. Our findings highlight the urgency to understand the complexity of COVID-19 within the health workers' quarters and a pandemic with their complexity and uniqueness. And I'll let you to read the rest of the slides in your own time. Thank you. Salvina, back to you.
For the enlightening presentation. And this research, I would say, is an eye-opener to us. When we are talking about COVID-19, actually there's a group of people who are actually at the front liners, and there are many of these people who are getting COVID-19 infection, and as such, there are also death happen because of this situation. That is the current situation in Indonesia. Mr. Rajan, would you please share with us the current cases in Malaysia now? Okay, thank
Right.
you, sir.
Thank you, Ms. Moderator. Okay. Currently, as of yesterday, Malaysia has recorded a total of 13,993 cases, with active cases of 3,351 currently. And out of that number, 40 cases are in the intensive care unit. And overall, we can say that the rate of recovery is about 75%, more than that, 77.2%. Right, the recovery rate is quite high in Malaysia, and the number of deaths is below 1%. Right? Currently, it stands at 1.01%, so definitely it's going to be less than 1%. We must understand that all this number of cases were detected by actively taking samples. The more the number of samples that we take, the more number of positive cases that we can detect. So currently, like in Malaysia, the rate of samples that have been taken are about 41 tests for every 1,000 people, which is equivalent to South Korea. Whereas, like if you talk about USA, they are taking about 27,000 tests. In Japan, they are only taking about 4.5% of the cases that are positive, right? and the number of samples they are taking is about 7.4 tests per thousand population. That's very low. So if you compare to Malaysia, like 40,000 tests, 40 tests per thousand people, that is more. See, so the more the samples taken, the more detection that we have, the more cases that we can have. Like in Canada, the UK, and United States and Australia, they are taking like more than 100 over tests per thousand population, because primarily because of the facilities that they have. Like in Malaysia, currently we have about 58 labs that are conducting the RT-PCR test. And we are also engaging the rapid test kits for the testing as well for antibodies. And the percentage, if you look at the overall percentage, 78.2% of the positive cases are allowed to be quarantined at home currently, as opposed to the earlier stage where most of them will be hospitalized for treatment. Back to you, Ms. Moderator.
Thank you, Mr. Rajan, for the information. So indeed, the positive cases detected in Malaysia is increasing day by day, and by yesterday, actually, there are 40 patients from the active cases already admitted in the ICU, still in the yeah. Um, the initial of this pandemic can be traced back in December last year. So, however, each country has responded differently to this situation. Dr. Najmah, so far in Indonesia, what action has been taken by the government?
So, like I have explained in the slides, that there is different propagandas that were announced by the government to society from the March till to the October related to COVID-19. So, but I will explain the three main propagandas that they were introduced by the government. That firstly, social large-scale restriction or pembatasan sosial berskala besar in April 2020, and secondly is the new normal, and then change into the adapting the new habits in the June to July 2020. And thirdly, the mini lockdown. We will see what it means in the next few weeks. However, because of our culture, our Malay culture also, the culture of saving face, jaga muka, jaga malu. So, and a quick change of propagandas and COVID-19 mitigation plans to control COVID-19, the strategies were not able to control COVID-19 cases in Indonesia without the involvement of the grassroots initiatives. So we argue that the Indonesian government did not have a clear concept and strategies with a lack of evidence-based research to control COVID-19. So Indonesia should focus on problem-based solving, not project-based solving. Thank you. Next, Dr.
Thank you, Dr.
Sofana.
Najmah. Yes, thank you, Dr. Najmah. In Malaysia, we have implemented a movement control order, and this has been conducted in stages. Mr. Rajan, if you will, can you tell us what is MCO or movement control order and the phases we have go through so far?
Okay. In Malaysia, we started to have our lockdown beginning 31st, 18th of March this year. Okay, and that we call the movement control order was imposed. That was the phase one of the movement control order, and it took place from the 18th of March to the 31st of March this year. So during that time, a lot of people were caught unaware of the situation, and actually we were learning from the episode. All right. Then it further progressed into the phase two of the movement control order, which began in the 1st of April to the 14th of April. That was the second phase. And then still we call it movement control order. Then it was prolonged into the phase 3 and phase 4 of the movement control order till 3rd May 2020. And after that, the number of cases were started to stabilize. The number of cases were started to show some signs of going down, and the government proposed that we convert to the Conditional Movement Control Order, or CMCO, from the 4th till the 11th May 2020. That was the phase 5. And following that, it was phase 6, still under the Conditional Movement Control Order, and it was done until the 9th of June 2020. And the government then proceeded on to do the phase 7 of the Recovery Movement Control Order. That is the RMCO, Recovery Movement Control Order, based on the number of cases that are stabilized, based on the number of positive cases who were warded, based on the number of the recovery rate of the patients that were found positive and in ICU and other treatment. So during that time, the Recovery Movement Control Order, a lot of relaxation of movement were done, and the public were, they were trying to recover their economies. Basically, during the movement control order, a lot of people were affected, a lot of jobs were affected, and basically their daily sustenance were affected as well. And then people start to move out, and currently, beginning early of October and early October, we have imposed targeted enhanced movement control order, meaning that places with clusters with numbers higher than 40 are placed in red zones, and these red zones are put under the um, targeted enhanced movement control order in Malaysia. And currently we are conducting that. That means those clusters with numbers more than 40 cases will be placed under the TEMCO, targeted enhanced movement control order, whereas the other zones will be like the green zones, which do not have any cases, and then the second zone will be the yellow zone with 1 to 40 cases. And with this, we believe that the prevention and control of COVID-19 in Malaysia will be done on a recovery route, okay, so that we can come back to the original status of the country. And the minister, our prime minister, announced the TEMCO after discussion with the Malaysian Security Council, and they have come up with this plan so as to not to jeopardize the economies of the community, of the public, as we have seen a lot of people being affected by the economies and the daily sustenance. Thank you.
Many people actually did not understand the different phases of MCO implement in Malaysia. March until today is still under the MCO, just that the phase is different. So thank you, Mr. Rajan, for the clarification. Just for a few reminder to the audience, you can leave out comments, question in the comments chat. Yeah, Willow. Okay. In this the many countries has imposed restriction movement, and this has been staged in the phases. For example, we have lockdown in Malaysia and also Indonesia in March, last March. So to Mr. Rajan and also Dr. Najma, maybe Dr. Najma would like to talk about it first. How are the public reaction and the response toward this lockdown in Indonesia?
Okay. Interestingly, in Indonesia, we didn't apply the lockdown, but some people say that PSBB, the social large-scale restriction, is like partial lockdown. So we study from home, we work from home, and almost 3 months, and we pray, Friday pray, eat pray from home. Yet, after the government announced the new normal on July, that some part of people interpret is back to normal. No, there is no mass rate, and we can go outside. So it's interesting. It just seems like normal, although the government always promote the strict health protocols. Please use mask. Please wash your hands. So the government always remind us, and a lot of news, television also always remind us. However, most of the kids nowadays, fortunately, still study from home. So it's almost over 7 months kids with us. So it just, they said, when we can go to school. So the public common statement is interestingly that they say that why you close the mosque, the schools, but you don't close the mosques, the malls, and other gathering spots. So it's interesting. So there are also reported the people on another side, in social economic side, people lost their jobs and decreasing the salary. And in family lifetime, it's interesting the number of divorces were
Oh,
increased, and the majority women ask for divorces, so around 70%. So it's interesting the phenomenon, social, economic, culture, to understand about the concept of partial lockdown in Indonesia. Thank you.
Thank you, Dr. Najma. Yes, of course, this COVID-19 during the lockdown, it affect all the people because of the economy situation. But we are, putting concern on their health, basically. Mr. Rajan, can you comment on the Malaysia side, how the public reaction and the
okay.
response toward the lockdown?
Right. Thank you. In Malaysia, we too face the same problem as what Dr. Najma has spoken, that has happened in Palembang, in Sumatra. Uh, and a lot of people were being affected, as I was saying earlier. And because of this lockdown, primarily many did not understand what was happening. So the risk communication, there is a breakdown in risk communication. I would say that I personally would say that there is a breakdown in risk communication, as people were not ready for the lockdown, and this really escalated to a lot of issues like buying groceries and whatnot, and then later on it was toned down, and then the head of the family members can be allowed to go and buy things. Their daily life sustenance was made available through that. But all in all, I think the majority of the public were not happy with the situation, as it actually it prevented them from from going to work. Although some of us are allowed to work from home, but many others were not and were retrenched, basically because of the lockdown. And this has affected their normal lives. And even until now, we are feeling the effects of that lockdown. Basically, many of them are without jobs. Many of them are without jobs. The other advantage of this lockdown was a lot of them has gone on to other businesses. They improvised, you know, they did not, they took it positively, and they have developed their own businesses, like online businesses. Some even went to YouTube, to do some videos, and then uploaded videos about cooking, about baking, and these are the positive signs of the lockdown. And the other one is the close relationship with the family members. All the families were becoming closer. Everybody was in positive mood, and the relationship was strengthened here in Malaysia, I would say. And a lot of opportunities were opened, like food sending of food, and then the online trade was also grew tremendously. Thank you.
Thank you, Mr. Rajan. Yes, I remember during the lockdown, there are a lot of people call as a panic buyers, yeah, all going out and buy supplies and all. In fact, we have recently increased spike numbers in the active cases in Malaysia, and even without the announcement by our Prime Minister, there are some people which actually already feel very afraid of the situation, afraid that the lockdown will happen, and go buy and all the things supplies to prepare for any lockdown if it happened. Yeah. So this situation, this pandemic is initially start in I think in December last year, right? Initially in Wuhan. So coming from that, we all watched that from our countries. We know about this happening in other countries. So we see the situation happen in one place in China, and the number keep increasing and all, and we keep thinking that it might come to us. And after that, it coming through like the situation, it goes to the country and become a pandemic. And we see that how our government actually taking action on this, how they are managing this from the start of it in the December, in the January, when they start going to the cases reported in other countries, yeah? And until today, when there are some decrease in number and suddenly spike in numbers. So, Mr. Rajan, from this situation that we go through, what have we learned, and what you think that we can do better in the preparedness of the disaster, I would say?
Okay. One thing that we have really learned is that we have to be prepared for any emergencies. Okay, so we need to be prepared. So I would say that our system, our government system of operational emergency was intact, was good, because we were having a lot of emergencies during our floods, and this has actually helped us. You know, the Malaysian Security Council has really did a very good job, all right, handling the situation, you know. But there are things that we are also learning through the episode of this COVID-19. Of course, all the countries who were facing the episode of COVID-19 were learning a lot. So we too learned a lot, and we are actually improving on our preventive and control measures. And all these measures have been going on, and it's still going on. And what we learn is, the other part of learning here is sharing of knowledge. It has gone international. Like a lot of countries, like I know about 22 countries that are really going into producing the vaccine, and everybody is sharing the data. And I'm very hopeful that one of these fine day that we will get the vaccine. No doubt the vaccine only gives at least the minimum 50% protection, but with the vaccine we can rest assured that many lives will be saved. The priority in COVID-19, tackling the COVID-19, was saving lives, right? Saving lives. And with the facilities that was available, like the hospitals, and then the staffs, the medical staffs, and all. So with the number, we were afraid that many more cases would come. But with the implementation of the lockdown, with the implementation of the movement control orders, we have actually in Malaysia minimized the impact, and that was a lesson learned for us in for the future, for future outbreaks. And it's also a lesson learned for other countries, and they are looking at Malaysia on how we achieve this. In fact, Korea and Malaysia are the two most looked at countries on the issues of COVID-19. We are learning. I mean, other countries are learning from this, and actually, whatever we have done so far, we also learned from the episode. So outbreaks of diseases can vary. In future, it may be more virulent, maybe more. Maybe the transmission rate will be higher. So we would not know. I would like to say that through my experience, I was involved with SARS in 2003 when I was working with the Ministry of Health. And I was also involved with the influenza AH1N1 in 2009. Then we were also handling the MERS-CoV. and then currently now with the COVID-19. So what I see that there is a change of policies, there is a change of methods of approach, there is a change of methods of testing, and then there's a change of the availability of facilities to do the testing. And now it's like more localized, like every state has got a testing facility now, and results can come out fast, and prevention and control activities can be done at a much faster rate. With that in mind, I would say that we have learned a lot from this episode. And looking back, I think we are more prepared in the future for any eventualities. Thank you.
Thank you, Mr. Rajan, for the input. Dr. Najma, the cases reported in Indonesia, I would say, looking at the graph, keep on rising, at least within these 30 days. A partial lockdown has been imposed to a certain area. So, in your opinion, what do you think are the direction of control in the future, looking at the trend of cases now?
Okay, thank you very much. So we should understand in Indonesia context, and over 70% of population work in informal sectors. So it means that they earn money daily. So if they didn't go outside, they will not earn money. So within the lack of economic support, because some people get the support, other people don't, and within that kind of situation, it's important to understand what the grassroots want. And secondly, currently that the belief of corona start to vanish, and some people say that I didn't believe in corona again. Even the current statistic data say that 17% of Indonesian people, so around 40 million people, didn't believe in corona again. And based on our qualitative research data, within the family perception, then we conduct within the last 2 months, that the common answer that they do not believe in corona again, it's just propaganda. And some of them try to, previously they believe in the corona, but nowadays they say that I don't believe it again. So based on the Indonesia context, that we aware that a lot of uh, expert outside Indonesia criticize Indonesia how they respond to COVID-19. At the best, the response has been negligent. At the worst, it has been deliberately misleading. But as it often the case that when the government fails to react, the grassroots organization steps in, fill the void, that we call it gotong royong, or working together in Indonesia. By supporting the communities, it's meaningful, it's small scale, with the grassroots initiative restore the hopes in humanity, kindness, kebaikan, sodako, care for each other in our country. So we learn a lot of kindness. So 3 lessons that I learned from our community initiative in my community, that firstly, the government should empowering community. So what I learned from our social project, that it is useful for the policymakers and other stakeholders, is that with a little support and encouragement, local community can effectively mitigate COVID-19 from the small scale. We call that RT, airway in our cultures. And our second learning useful for policymakers and stakeholders, that providing information in local languages. Remember, there is low health literacy. We
Yes.
understand that, but people in informal sectors, the only thing what we can eat today, not what is COVID-19. You say
Yeah.
COVID-19, blah, 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 but my family need to eat. So
Yes.
local language through trusted members of community is an effective way to enabling people to understand, follow health protocols. What we did in surrounding me, we call that penyuluhan keliling kampung, or COVID awareness for kids during the pandemic. So
Mm.
we go around, while a lot of health workers are afraid to come to the community, but we come to the community. People who stay there, they are brave enough to go to the community. And secondly, the university students who attend our conference today, this is our power. This is useful that for
Right.
policymakers and stakeholders, to including the university students and the COVID-19 online response. Our students is Instagram, Facebook, they are the main user of that. and it is beneficial in communicating information to communities. We as a lecturer, we appreciate their effort when they make a videos, they make a posters, we give them a good mark. It is what we can do. And you know that when I try to my subjects, that one video can be watched by over 20,000
Yeah.
watches, over 100 people share the video, so it motivates them to good mark. But for us, it's good for people to increase the literacy for the young generation. And thirdly, it's interesting with the low reported cases in our culture, because like Mr. Rajan said, in Indonesia it's a bit low access to COVID-19, because we only around 10,000 per 1 million. So compared to Malaysian is 40,000 per million, or even Singapore is 400,000 per million to access the COVID-19 test. Predictive modeling is necessary. So we should work with epidemiologists, with biostatisticians to understand that policymakers and other stakeholders, these predictive numbers doesn't make you scary, but make me more aware that we are
Yeah.
not in the good condition. So
Correct.
engaging the health organizations such as public health organizations is a good way to increase health literacy about the danger of COVID-19. And also we learned that predictive modeling through epidemiology, it is important to show more realistically the number of the actual cases compared to reported now. So it's just like iceberg phenomenon. What is the reported cases of COVID-19 now? Thank you.
Thank you, Dr. Najwa. In Malaysia, we almost flattened the curve by July and August this year. However, there is sudden spike in the active number of cases detected this month only, owing to the cluster in Sabah and Kedah. Mr. Rajan, is it even possible to strive for flattening the curve in the near future? And would be possible another lockdown imposed here in Malaysia?
Okay, thank you. Regarding the lockdown, I would say the future, I think in the future there won't be any lockdown, but we'll be targeting the clusters as well, the clusters. It will be a TEMCO, I mean, that means targeted enhanced movement control order. That means when we identify the clusters, we go to that targeted area and do the control work. So that will be more, it will be better for the public as well. And that will be a smaller area, and we can do a lot of things there. In fact, like what doctor said just now, uh, we actually need to educate the public more. The public needs to understand what is COVID-19 is all about, and why are we doing all these control works, and they need to understand that first. And then why we say that we need to enforce like personal hygiene, like hand washing, using sanitizers, wearing masks, avoiding crowded places. These are the things that how we can avoid being infected. So once we are infected, let's say there is a positive case of COVID-19. If you are infected, you can transmit that to 3%. According to the World Health Organization, the R naught for COVID-19 is 3. 1, you can go to 3, and 3, you can go to 9, and so forth. It is an exponential increase. As compared to influenza, the R naught for influenza is 1. So 1 can go to 1. So which is easily controllable. And then when we talk about R naught, it's not actually that the R naught is actually the reproductive ratio for that COVID-19. And when we talk about transmission efficacy, we should include the series interval. That means like we call it SI, series interval, and in combination with R naught. For example, like COVID-19, the series interval is about 3 to 5 days, as compared to influenza. Influenza has got a series interval of 2 days. So actually we can control this COVID-19, and we can even flatten the curve. There is no doubt in my mind that we can achieve our targeted goal. And with the help of the community must be mobilized to help us. and prevent the spread. So, like what was mentioned just now, that there were clusters in Sabah and Kedah. Like in Kedah, for example, a very good example in Kedah, there was one cluster which took place in the prisons. All right, and prison, as you all know, is a confined space. So when you sit in a confined space, the transmission rate will be much higher. You are inside a confined space. Whereas if the public is out, and let's say you go to the shopping mall, of course you have to wear the mask. You have to take all other precautions as well. So these are the information that the public needs to have with them. And if, with this knowledge and with this strength of knowledge that we have with the public, I am very sure that COVID-19 can be over in a matter of another 3 to 4 months. So we are looking forward to that. And with the vaccination coming around, so that will also help us a lot. Thank you.
Thank you very much, Mr. Rajan. Dr. Najmah, I believe that what Mr. Rajan and Dr. Najmah has said before already conclude on the advice to the public on what to do in this challenging time. Thank you again, Dr. Najmah and Mr. Rajan, for the opinion and the knowledge they have shared in this session. So this session is a great opportunity for us to know more on this COVID-19 out of our boundaries. Yeah? More importantly, the prevention and moving forward for this pandemic. So before we end, we will have a little bit of Q&A session. So I will scroll through this question in the comments, and we try to answer as much as possible. So there's one question from the audience. What do you think on this? Why that initially we are not able to detect the COVID-19 during the pandemic, but we are not able to detect the COVID-19 in our countries. So maybe Dr. Najmah can share her opinion on this.
It's interesting. In January, February, there were a lot of suspected COVID-19, but the result shows negative. But currently, we know that the laboratory were not able to detect the COVID-19 that time, because we have the laboratory with the specific of coronavirus, but not COVID-19. So this is one of the best opportunity that we deal with Indonesia compared to other countries. And secondly, like I explained before, in our culture, like saving face, jaga muka, everything should looks good in front of the president, in front of the ministry. So it's one of the obstacles in our culture to say the truth that we are not ready. We should be honest that we are not ready. So we can prepare well rather than we say pretending get ready, but we miss the opportunities, because in the January, February, there are a lot of probable suspected COVID-19, but the result shows negative. And in next few weeks after we announce the first cases, they said that they check again and they said that the result is positive. So there are a lot of missed opportunity, particularly for health workers who think that everything is fine between January, February, but the fact that it's no. So they are the main one of the vulnerable groups in the COVID-19. And I remember that in the March, we have shortage of personal precaution equipment. You know that what the health workers use? They use the raincoat to protect themselves, because we should understand their position. They have family. They need to protect. Within the lack of personal precaution equipment, they use the raincoat. So we should appreciate how the resilience of Malay culture, how resilience of Indonesian and Malaysian population. So it's a great learners. There is obstacle, but sometimes we initiated to overcome that by our own grassroots initiatives. Thank you.
Well, for Malaysia, we too face the same
Najmah.
thing. In Malaysia, we too face the same thing. And during the early months of January, there were a lot of backlogs of tests. We took a lot of samples, but we did not have the facility to run the tests. So it was a backlog then. So when we reported the daily cases, of course, the number of cases were very high. okay, because of the samples taken and a lot of backlog. And eventually, every day we were looking at, hundreds and hundreds of number of cases being positive. And that actually relates to the detection, how well we are detecting the case. And that is actually a positive sign, but people were scared about the numbers. So when they look at the numbers, they got really scared. So when they got scared, they're really looking forward to something to be done by the government. All right. So that's the thing I said, like, we need the information to be channeled. The risk communication about COVID-19 must be channeled fast. And with the new technologies that we have, like the social media, the Twitter, and a lot of information was going out, but a lot of fake news were also going out, and that made people more scared. And this was happening in Malaysia, and our communication minister had to form a task force to really look into this matter. And until now, we are still having a lot of fake news going on, and this was such the case. So I think the public needs to be educated more. And how do we educate this? So we have to start in schools. So basically, we need to educate our children so that they can bring this information back home and inform their parents and their siblings as well. I know a lot of schools are closed, but now, like in Malaysia, we have already started to open. And I strongly feel that the environmental health practitioner must be placed in schools. It's not only for COVID-19, they can do a lot of control on vectors, on dengue, fever, and all the diseases, as well as looking after the sanitation, the air pollution, the water quality, and all in schools. So it will be a great area, is what I learned so far. It's a necessity now to have all these environmental practitioners placed in these places of concern, especially in universities, in institution or training institution, and they are able to do some form of prevention and control work. Thank you.
Okay. Thank you, Dr. Najma and Mr. Rajan. Maybe we will have one more last question. This is from student, I believe, on the experience in implementing social restriction or PSBB in Indonesia and in Malaysia. How does the Malaysia health policy regulate the healthcare facilities during the social distancing? Okay.
Uh, so I will answer that question, right? Okay. So in
Okay, thank you,
Malaysia,
Mr. Rajan.
all right. In Malaysia, when we are talking about social distancing, why we are implementing the social distancing, right? First of all, we have to understand that this is because the virus is airborne, and anyone who sneeze or cough, all right, the droplets can go airborne, and then you can get enough doses of that virus, and then you can fall sick. If your immunity level is high, then you will be protected. All right, but not everyone has got the same immunity level. We don't know who will get the COVID-19, who will not get the COVID-19. So that's why the government has put in like things like the avoiding crowded places, confined spaces, and then get your distance with the social distancing. Actually, it's not social distancing; it's personal distancing now. How do you distance yourself from the other person? All right, it is a personal distance now. It's not only social distancing. Like in Malaysia, we have opened up all our temples, malls, and all that. So I have gone to a wedding in an Indian temple, and I've seen the social distancing or the personal distancing that they are doing there. So it is not working. Although they are wearing their masks, they are also using the sanitizers, but this has to be enforced. But knowing this, why must we enforce this? Why not the public do it on a self-regulatory basis? Why not we do it as a precaution for us? It is personal hygiene. It is personal hygiene. And it's not only for COVID-19, it's for all other diseases as well. It is for all other diseases as well. All right. We can talk about food and waterborne diseases. We can talk about other airborne diseases. All right. So basically, the personal hygiene has to come in. Like wash your hands when you're out. Wear the mask properly. You know, not below your nose or under your chin. And then when you're coughing etiquette, or you're shaking your hands. I mean, with your friends, right? So this is not the time to do that, and a lot of things that you have to remember. And there are a lot of people, like for example, like in our universities, we have lifts, and there is a signboard saying that only 4 can enter. But if you turn around, you look, there are 10 students going in, right? There is a signboard there, clearly written and all that, but still 10 students go in and they are not actually, following the rules and regulation about social distancing or personal distancing. You know why? Because they are in denial. They are saying that they will not get it. They are in denial. That's the reason why we are getting more cases now. All right, that's why we are getting more cases. A lot of people are not into it. They are not following what the restrictions, the controls that we are supposed to follow. So these are the hindrances or the barriers towards preventing the spread of COVID-19. And especially like in institution, we should, we do not want every corner to be, we have enforcers in every corner, and we don't want to tell every student that, hey, you have to wear your mask, hey, you have to go and do your social distancing, hey, you have to, sanitize your hand. We don't want to do that. How long can we do that? So it's best that each and every individual is responsible for their action. Each and every individual must be responsible for their action. So again, I would say, please, if you want to, flatten the curve or bring down the number of cases or prevent from being infected, avoid crowded places, avoid confined spaces, you know, uh, your social distancing or your personal distancing, wash your hands, wear a mask, all right? And be warned of the things that you must not do. For example, like coughing and sneezing, in public or in a classroom and all those things. So we are the one who are held responsible for all those things. Who are the one who spreads this? People who do not follow the rules and regulation about prevention and control of COVID-19. Thank you.
Okay. Thank you, Mr. Rajan. Maybe one more last question. Okay. This is on the why have the different price of swab tests, RT antigen and PCR? Is it more expensive in Indonesia rather than the price in Malaysia? And WHO not control the price, or the Malaysian government gives the discount for this? Okay. Maybe Dr. Najma would like to
Mr.
answer this,
Razan.
or
Yeah.
Dr. Rajan, Ms. Rajan? Yeah.
Yeah, Mr. Razan, it's very interesting in Indonesia because last a few months the swab test is almost 2 million rupiah,
Yeah, that's
around 200.
expensive.
Yes, and nowadays they changed into the 100
Rapid test kit.
1 million rupiah in rupiah. So it's around how many ringgit? 1 juta, 300 ringgit.
300.
So now but for the rapid test, it's quite cheap. So it's around $10 to $20. So but it changed after so much protest. So we are so curious how about in Malaysia. So that's why there are a lot of hoax about mengcovidkan pasien. So in Indonesia, the health workers try to make negative cases to be positive because there are a lot of economics behind it. There is the gossip behind a lot of that why population didn't believe in corona. So how in Malaysia, how you control that kinds of hoax, gossip, something like that?
Okay, like in Malaysia, I think our government was well prepared, and everyone had a, those suspected cases were taken samples, and those samples were tested. And the gold standard, as you all know, is the RT-PCR. And now we have also introduced another test, the RT rapid test kit to test the antibodies. So, when both comes together, the sensitivity of the test becomes 80%. So I would very much like that maybe other countries will help the other Asian countries which are not able to produce cheaper samples and cheaper tests. As when we do a more number of testing, the more number of cases that we detect, that will reduce the number of people who are hospitalized. Right? Maybe they are now like we are already talking about asymptomatic cases. That means cases that are around with positive COVID-19, but they do not show any signs and symptoms. If we read the scientific data on COVID-19, COVID-19 can be transmitted 2 days before the onset of the symptoms, 1 or 2 days before the onset of the symptoms, and 7 days after. So during that period, if the virus has not produced enough antigen, we cannot do the antigen testing. It must reproduce. So sometimes we have negative results for the antigen testing. So the current standing is RT-PCR, reverse transcriptase polymerase chain reaction, and the rapid test kit for antibody testing, which is done 2 weeks or during the recovery period. So these two should come hand in hand, and we will be able to control the cases. So regarding the cost of the tests in Malaysia, we are able to do it. It's not that expensive, as the government is putting in all effort in Malaysia so that everybody gets equal rights to be tested, all right, and then equal right to be treated. And we are doing as much as possible to control these outbreaks, all right, and the number of cases here in Malaysia. I'm so sorry to hear that it's very expensive in back in Sumatra, but things are like that. It's like things happen in a sudden, and then we are not prepared for it. Of course, things will gradually change, will move to better, and then we will have more things to be done. Earlier, like in Malaysia, we did not have enough number of testing labs. Now we have like 58, and we are rest assured that the test will be tested and the results will come out within the 24 to 48 hours, so that the prevention and control activities can be carried out. I'm so sorry to
It
hear
is
that
very
it's very expensive there.
yeah, it's very interesting because we have some free access for COVID-19 tests, but in some circumstance you can get free, but if you cannot get the free, you should pay something like that. So it's very interesting.
Same here.
And how the government control the price for the test.
Yeah, even our mask prices are also being controlled here in Malaysia, the mask. So earlier it was like 2 ringgit and Malaysian ringgit. Now currently you can get it for like less than a ringgit. It is being controlled.
Yeah. Okay, thank you, Dr. Najma. Thank you, Mr. Rajan, for joining us for today for such a brilliant. This is very interesting. We know the opinion of both experts in this field. Hopefully, we can have another similar session in the future, collaboration between University Sriwijaya and also MAHSA University. To all audience, thank you for joining us. Please visit our website and social media page for more webinar from us. Okay, so see you soon.
Stay safe.
Thank you very much.
Yeah, stay
Thanks,
safe
stay
and
safe. Yeah.
stay positive about the actions
Bye.
that have been taken, and we hope that everybody will be, doing their part as well. Thank you.
Yeah, thank you very much for MAHSA, and I would
Thank
like
you very
also
much.
thank you for our Dean Naniarti and Asmari Aini to organize this great opportunity so we can learn each other.
Yeah, thank you.
Thank you,
very
Nur
much.
Salvina, Savarina,
See you soon.
Mr.
Bye.
Raja.
Thank you, moderator.
Bye.
Thank you, doctor. All right. Thank you,
Thank you.
Najma. All right. See you all. Bye.